So if there's any questions from the audience, feel free to come up to the mic and ask the questions.
I'm wondering about on the 3 months of therapy, is if there was ever any consideration of dropping the oxalic but continuing with the fluoropyrimidine, and if that makes any difference in the long term.
Yeah, so that works. So when we designed the whole collaboration, it was quite clear that we couldn't have a 3-arm study. You know, it's just impossible to do a 3-arm non-inferiority study. So in clinical practice, what I've done is when I talk to patients, we talk about especially the high-risk tumors, the uncertainty, you know, these small uncertainties surrounding the duration of therapy in these patients. I started with Capox, and after 3 months of therapy, just stopped oxaliplatin and continued the fluoropyrimidine. I think this is a clinically wise decision. I don't have any data on that, but I think it makes a lot of sense. Now, having said that, I also believe the data are strong enough to see if you really have a continuous administration of a fluoropyrimidine, you probably don't need more. In a cancer that survived 3 months of this continuous treatment probably doesn't, and micrometastasis probably won't be affected later. And we have the data from the ICAHO study. Now, let me give you another idea. So the Capox, FOLFOX outcomes differences were such a surprise. We had a statistician telling us, this is what it is, and the clinicians were saying, no, we don't believe it, for months. And eventually, the more you dive into the data, the more you look at it, in the end, that's what it is. It's no deny, we can't deny it. I mean, I can't close my eyes and say this is not real. This is real. We have almost 13,000 patients in Israel. And then you look at the data and say, you know, what else happened with capecitabine? You know, interestingly, capecitabine recently had a resurgence in adjuvant therapy. Triple-negative breast cancer, if they don't have a complete response, you know, breast cancer is now, standard of care is after surgery, capecitabine. Pancreas cancer, biliary cancer. We have used it along in rectal cancer anyway, and we have data actually that the curves, 5FU versus capecitabine trends a little bit upwards. When you look at the one trial where Capox and FOLFOX were actually randomized, the AVANT trial, which added bevacizumab, it's a confounding factor potentially, the Xelox or Capox curve trends above the FOLFOX curve in disease-free survival. So there is so much data that we just haven't looked at right, because we love our FOLFOX. Now, it's just everyone's FOLFOX here. Now, Capox, you don't need a port. When you can administer oxaliplatin through a peripheral vein when you put a warm blanket over the arm, you know, it takes the pain away. Capecitabine, of course, you need to find the right dose for individual patients, of course. But for a society, Capox is cheaper. You don't need a port. You don't need nursing time. You don't need surgery. That's why in the UK and in Japan, this is what they use. Sorry, long answer for a short question.
So I wanted to make a point on something that you have already sort of give some hints to answer my question, but what do you think are the individual contributions of capecitabine versus oxaliplatin on the Capox, right? Because we have been hearing that maybe this benefit from Capox is related to the higher dose of oxaliplatin to hitting the disease early. I don't think that that's the answer, because when we look at, for instance, trials in the metastatic setting that have compared different doses of oxaliplatin, FOLFOX4 versus FOLFOX7, there was no difference in response rate, right? So what do you think are the individual contributions?
That's actually, I would have exactly made the same point as you did. You know, the comparison between FOLFOX4 and FOLFOX7 compared 85 milligrams to 130 milligrams, really what we see here, and there was no difference in response rate. So I believe that the main contribution here, and I tried to highlight this, is really the fluoropyrimidine. Nothing in the adjuvant therapy in colorectal cancer is more important than the fluoropyrimidine. And I believe, you know, if we could really put a line in a patient, give 5FU continuous infusion for 3 months, you know, and add oxaliplatin to it would probably be the best, but we don't have the study. But the continuous administration of this fluoropyrimidine is really the key in my eyes. And again, it took half a year for 20 international oncologists to look at the same data and then finally say, yeah, the statisticians were right. Quite sobering, actually. Yeah.
in view of the adjuvant data that you showed, do you think the same thing would apply for capecitabine in metastatic setting compared to 5-FU?
You know, not everything that we see in the metastatic setting translates into the adjuvant setting, and I would also think that's the truth for vice versa. I mean, so I think we can ask probably in a different way now, how do we translate these data, for instance, to rectal cancer? What about post stage 4 NED? You know, when patients get liver resections, now should we switch the adjuvant treatment to more a capecitabine oxaliplatin-based treatment? And in rectal cancer, I would think yes, you know, because it's very similar to colon cancer in its outcome. And in stage 4 NED, potentially, yes. I would not go that far to really substitute get rid of FOLFOX, you know, in the palliative setting. It's very, very different disease again. And there is actually one meta-analysis a long time ago which pooled all the FOLFOX versus CAPOX data, and there was actually superior response rate for FOLFOX over CAPOX. Again, but this is a different scenario. Micrometastasis is very different. They might need this continuous fluoropyrimidine exposure. So I can give you another, you know, I think what's important too, and again, I'm not only because we invested about a decade of work in there, but I do believe it's important for patient care. I have a violinist, a professor of music at the University of Iowa as one of my patients, and he had a high-risk stage 3 colon cancer 5.5 years ago. And you know, when we talked about adjuvant therapy, he was afraid of being able to play the violin and lose the capacity. And so we opted for 3 months of FOLFOX, at that time. And he knew that this trial was ongoing. This trial was ongoing, and he said, he came for his 5-year final visit in May, and I just had the data about a day before that. And he said, are the data out? And I said, yes, I have them here. And, and I showed him, I was like, God, I'm so sorry, FOLFOX, high-risk tumors, there's a potential detriment of 2.4% in disease-free survival estimate. And he looked at the data and said, thank God I didn't do 6 months. And because he could play his violin. So what the difference we look at from a statistical perspective might or might not be relevant for patients in their lives. And 2.4%, like in breast cancer, would be, oh my God, you're killing patients. But in colorectal cancer, it's like, this patient said, I'm so happy we decided to do 3 months. So whenever we color code things, non-inferior, inferior, superior, whatever, I think what this large database gives us is a framework to discuss things with our patients. And it can be that patients make the decisions different than we think they would, but we can at least inform them. Before, we had this analysis when patient asked me, so when I stop now, what do I lose? And I said, I don't know. Now we do, and we can integrate patients' decisions into our algorithms here.
So I've always been curious about the difference between metastatic disease and adjuvant in terms of irinotecan and oxaliplatin and why that should be. So do you think with this new thought about continuous infusion or continuous administration, at least, of the fluoropyrimidine, should we be looking again at a non-neurotoxic adjuvant therapy?
Yeah, it's a very interesting point. So a little bit of a background. I mean, the fact that irinotecan is not established in the adjuvant setting is based on several studies, including the PETAC3 study, which was FOLFIRI versus leucovorin. And this was about 2 years after the MOSAIC study, the FOLFOX data came about. And for onco nerds, it's kind of important to know that the disease-free survival definition differed between the MOSAIC study and PETAC3. If PETAC3, FOLFIRI, had used the same definition as in MOSAIC, it would have been a positive study. So we would have now looked at irinotecan as part of adjuvant therapy, or potential part of adjuvant therapy. But it was a negative study based on the definition of DFS. So, but in the high-risk group of patients that are outlined here, there's actually positive benefit. So there are suggestions, and there's actually a Canadian trial that's ongoing right now, look at FOLFOXIRI in a high-risk patient population. and they're comparing it to FOLFOX, which I believe is a good idea, to see whether these patients benefit from, let's say, more intense therapy. The intergroup, the GI steering committee, unfortunately had rejected a similar proposal. So bottom line is, I do believe there could be a role for irinotecan in the future, but we need to wait for the Canadian data. Yeah, disease-free survival is not the same in every study. And again, this goes into the nerdy details, how studies are being designed.
As a nurse, I work frequently with colon cancer patients or rectal cancer patients that have long-term neuropathy. What do you prescribe to treat long-term neuropathy? It's a very, very important point. So one of the reasons why we all were so gung-ho on preventing neurotoxicity is because nothing really works. Yeah.
There's some data about duloxetine, in painful neuropathy, that kind of decreases the painful neuropathy by about 2 points on a 10-point scale. But as you know, a lot of neuropathies are not painful. They're just numbness, tingling. They're just bothersome, in patients. Sometimes it's burning feet when they walk a lot, but so bottom line is there's nothing that really works. And that is sobering, but I can tell you we have run, Mayo Clinic and NCTG in the intergroup, 10 trials, prospective trials, looking at everything that might work in diabetic neuropathy, that might work in other forms of neuropathy. Nothing worked in oxaloplatin neuropathy. So again, oncology nerdiness, it's platination of the DNA of the dorsal root ganglion. And you see structural damage to the nerves, really deterioration of the structure of the nerves after oxaliplatin when you have the long-term neurotoxicity. That is probably, it's one of the things that's just not reversible.
Thank you.
Axel, I wanted to go back to the prior question as to continuous administration of fluoropyrimidines in combination with irinotecan. What are your thoughts? Because there's some concerns with that regimen in U.S. population.
Yeah, so I personally do not like capecitabine irinotecan. So I know that some people use it. You need to dose reduce. It comes back to a trial that I was involved in while I was still in Germany. We had a high early mortality rate. At that time, we looked at 60-day early mortality, and we had 4 out of 40 patients die within the first 2 months, and mainly based on toxicity, diarrhea. So I personally do not use Cape-Iri. I know some people use it. If you use it, be very careful about and educate patients about diarrhea. And the NCCN guidelines do not recommend it, and rightfully so.
I think that's the main point. The NCCN guidelines do not recommend to use a Celery regimen or Cape-Iri regimen. Right?
All right, if there are no other questions, we're going to take a short break.